Welcome to the staffers, welcome to the visiting surgeons, and welcome to the Clinical Data Registries and Alternative Payment Briefing. This briefing was hosted by the Society of Thoracic Surgeons. My name, most of you know, is Keith Nauenheim. As you know, I'm the secretary, current secretary, second vice president for the Society of Thoracic Surgeons. I'm a thoracic surgeon from St. Louis University. Today we'll be hearing from both Dr. Jeff Rich and Dr. Dave Shaheen. Jeff Rich, sitting in the front here, he has extensive knowledge of the healthcare system. He was director of the Center for Medicare Management. He oversaw the regulation and payment of Medicare fee-for-service providers and privately administered Medicare health plans and the Medicare prescription drug program. Dr. Rich founded the Virginia Cardiac Surgery Quality Initiative, the VCSQI. It's a voluntary regional collaborative of cardiovascular centers. He developed a clinical financial database for the VCSQI, and he used that to demonstrate that improving quality can and does reduce costs. Dr. Rich has testified before Congress on numerous occasions, and most recently in the summer of 2013 when he described the critical role of the STS national database and other clinical registries in the payment system reform. Through his work with the STS and the VCSQI, Dr. Rich has proven that an interdisciplinary, team-based approach provides the best quality patient care and is the most efficacious way both to reduce costs and to enhance patient outcomes. Our second speaker is Dr. David M. Shaheen. I joked I should call him Sir David Shaheen. He's got so many damn titles. He's the professor of surgery at Harvard Medical School. He's vice president of the Mass General Hospital Center for Quality and Safety and associate director of the MGH Codman Center for Clinical Effectiveness in Surgery. In addition to his clinical career, Dr. Shaheen's been involved in health policy issues on behalf of the STS for more than 2 decades. He's been chair of the STS workforce on national databases and quality measurement task force, and has led the development and implementation of our database risk models, which is essentially the basis of our performance measures and our voluntary public reporting. Half of all cardiac adult surgery and nearly 60% of congenital surgery it is reported voluntarily in the STS public reporting program with the joint publication for Consumer Reports. So we are now one of the only specialties that actually can claim some transparency in terms of outcome results. Dr. Shaheen currently serves as a member of the NQF Board of Directors and is the founding co-chair of the PCPI National Quality Registry Network Steering Committee. First up is Dr. Shaheen. He's going to discuss the STS National Database, and next we'll have Dr. Rich talk about our society's ideas on how the database can be used to facilitate quality-based payment. Dr. Shaheen?
No, I'll just do this. Okay, right? Well, let me, for the staffers that are here, let me just start out with the history of the database. It really goes back to the federal government in 1986, so 30 years ago. The federal government, then CMS was called HICVA, and it released mortality reports that were essentially unadjusted. And this created a firestorm of controversy. Hospitals were being declared high mortality outliers, and one of the things that they were grading hospitals on was the performance on coronary bypass surgery. STS received innumerable complaints from these hospitals that they were being unfairly graded, that the risk of their patients was not being taken into consideration. And STS actually formed an ad hoc committee on risk factors for coronary surgery and issued a statement of concern, which was published several years later. And they made the point that when you're looking at outcomes, you've got to adjust for the inherent risk of the patient. So all the risk factors predictive of mortality have to be identified. And they also were very prescient in, and this is 30 years ago, remember, also recognized that you had to look at very homogeneous procedures or diagnoses when you're doing outcomes reporting. So you can't look at cabbage combined with something else. And they also, and I think this is very important, and I'll get back to this later on, they pointed out that it's not really the best way to measure quality just to look at mortality. You need to look at a much broader spectrum of the outcomes. including complications. So this led Dr. Clark, who was the founder of the STS database, to write in 1989 that it's time for a national cardiothoracic data registry. And in fact, now, 27 years ago, later, the STS national database is really the foundation for all of our quality activities in the STS. This is the organizational structure of the database. I don't have a pointer, but you can see over here the workforce on national databases with 3 specialty specific databases: adult, cardiac, general thoracic, and congenital. And then one of the unique features of the way we're organized is that we have also within the database some of the functional task forces that derive directly from the data that we collect. We have a task force on quality initiatives, a task force on quality measurement, public reporting, appropriateness, informatics, resource utilization, and so forth. So it's all integrated together. We have a full-time STS staff in Chicago. We have well more than 100 volunteer STS members who are on phone calls and meetings at ridiculous times of the day and night in order to keep this enterprise moving. We have multiple STS data vendors, so a hospital can pick whatever bells and whistles they want. And then we have a long-standing relationship with the premier academic and clinical research institute in the country, if not the world, the Duke Clinical Research Institute. I do want to say one thing about that. In our relationship, there are things that STS does on its own, devise strategy for the future, for example. There are things that we work together in conjunction with DCRI, developing risk models and performance measures. But then there's one thing that is totally out of our hands, and that's the actual analysis of the data and issuing of reports to hospitals and physicians. We have absolutely no way to impose ourselves in that process. So I ran the database for 6 years. I now oversee it, but I don't have access to the reports of a particular hospital unless they choose to make them public. So we always like to make it clear this is not a situation where the fox is guarding the hen house. Once those measures are developed, then their actual analysis and the outcomes are totally in the hands of this separate entity, the Duke Clinical Research Institute. This little snapshot of our current activities and participants, over 1,000 programs that participate in the STS database at the adult level, fewer in congenital and general thoracic, over 1,100 hospitals, 3,000 adult surgeons, 361 congenital, and 883 thoracic surgeons. Fantastic, thank you. With a penetrance, which I'll mention in a little more detail in a second, a penetrance of about 95%. And that's very important when you're thinking about legislation, when you're thinking about using STS data. It's important to know that unlike just about any other database that I'm aware of, we basically have the entire country. And yet we're voluntary, but we basically have the entire country. So what's unique about the STS database? Well, we have 27 years experience. We're nationally representative. We have these very clinically rich granular data elements developed by the content experts, many of whom are in the room today. We have structured data fields and standardized data definitions. And that's really quite different than electronic health records, where the data are completely unstructured, and something that's written in an EHR in Boston may mean a totally different thing in San Diego. So we have structure and we have standardization. We cover all patients and all payers, which differentiates us, for example, from a commercial database or from MedFAR, for example. We have very highly trained data managers. We're audited. We have risk models that are transparent, peer-reviewed, and then we have these multi-dimensional performance metrics. And I'm going to show you a few of these in a little more detail. First of all, our national penetration. We're in every state, and as you can see here, we have, I may not be able to see the numbers, but many states we have more than 100 programs in a particular state, every state in the country. And Dr. Jacobs, who is the current chair of the database, and a number of us did this study several years ago, looking at the national penetration and its growth of the database over the past decade. So these data are from 2012, so it's now 4 years later, and we suspect, given the growth patterns, that these numbers are higher. But if you take all programs in the country that submitted a bill for a cabbage to CMS, and then look at what percentage of those hospitals participated in the STS database in 2012, about 90%. And again, we think that's higher today. And it's pretty evenly distributed. That dark green color is close to 100%. And then if you look at the patient level, and you look at an actual patient receiving a cabbage and getting billed to CMS, and then you say, well, how many of those patients were in an institution that belongs to the STS database? Again, in 2012, it was 94%. So for all practical purposes, except for some federal hospitals, we have the entire country. And we're a voluntary database, but I think it's a testament to the fact that we provide value to members of the cardiothoracic community and allow them, we hope, to improve their practice. So let's talk about a few other aspects of the database. The data are clinical, they're granular, they're structured, and entered by these very highly trained and supported data managers. We have a lot of resources available for these folks. We're on phone calls with them all the time. They have direct access to STS and DPRI staff and surgeon leaders. And every year we have a conference. We just finished ours several weeks ago, where we have close to 600 of these data managers from all over the country that come and spend 3 days with us learning how to code accurately. And I think because of the fact that they are very, very committed to getting it right, we do external auditing by an organization called Telligent, and they look at about 100,000 data elements every year from over 100 programs, about 10% of the total programs in the STS database. And we have an accuracy consistently, year over year, of 96 to 97%. There's no other major registry out there that I'm aware of that does this and has this degree of accuracy. So this is completely different than data that you get from claims, which is essentially unaudited, or data that you get from EHRs. This is a very unique data source. So how do we use these great data? I've listed some of these here. We'll just go through them quickly because we spend a lot of time and effort getting these data. So what do we do with them? First of all, performance measurement. This is a picture of actually somebody that turns out is a relative of mine. Died a number of years ago. His name is Avedis Donabedia. He was a professor of health policy at the University of Michigan. And he developed the so-called Donabedian triad. It's the way we measure quality in healthcare: structure, process, and outcomes. But he pointed out, and I think we've now come full circle in measuring healthcare quality, he pointed out that outcomes are the ultimate validators of the effectiveness of care. For those of you that hear other organizations come and talk about outcomes, there are some that say, well, you don't really need to bother with risk adjustment. And remember, that was the problem with that 1986 publication by CMS or HCFA, that it wasn't adequately risk adjusted. And there are two things that are two conditions that are necessary for something to be a risk adjustment, to require a risk adjustment. It has to affect outcomes and has to differ in frequency between the institutions that are being graded. So we know that things over here on the left-hand side of this, the first column, like age, being on dialysis, or being in shock when you come to surgery, we know that those things have a tremendous impact on the outcomes of surgery. Now, if the incidence of those particular risk factors did not vary across hospitals, then we wouldn't need to risk adjust for it. But we've shown, this was a paper we published in 2009, that in fact, the prevalence of those risk factors varies dramatically across hospitals, even within the so-called interquartile range. So we have risk factors, and they vary across hospitals, so we have to adjust for them. And we've done this, these are our last set of risk models, and these risk models are currently undergoing revision. There'll be a new set of them this coming year. All our risk models are completely transparent, they're reproducible, they're published in the peer-reviewed literature, and that's something else that distinguishes us from many of the other rating and ranking systems that you'll see, including most of the commercial systems. They don't present this in a completely transparent way. Now, these are not the nuclear launch codes. So why am I showing you this bunch of digit numbers? Well, you can actually go to our website, or you can go to papers that I'll provide you. They're all available. They're on the internet, and you can find these data, pages and pages of it, for every one of the risk models we've ever developed. And these are called, for each one of the risk models we've developed, these are called the intercepts and coefficients. So what these numbers enable anybody to do is to reproduce our results. And again, there's nobody else that does that. So I think that kind of transparency tells you how certain we are about what we're doing. And we're happy to have anybody look at what we do. And the reason that's important is that, again, most of the commercial entities out there that are doing report cards do not do this. And the result has been sort of a Babel-esque enterprise in quality measurement where everybody comes up with different answers. We think the way we're doing it, being completely transparent, puts us in really a separate category. A couple of things to think about in terms of performance measurement. When we started out in cardiac surgery, we graded cardiac surgery programs based on one procedure and one outcome, so CABG and mortality. But there's some problems with that. First of all, CABG is declining in frequency. Valve surgery, aortic surgery, other kinds of surgery are increasing. So to grade your performance based on one procedure is a problem. It's also a problem basing it only on mortality, because mortality rates have fallen. They're now in the 1% range for many procedures. It's very hard to distinguish quality when you have endpoints that are that infrequent. So if you just think about it, this whole issue of comprehensiveness of measurement, these are 3 CABG survivors, 3 people that have come out of CABG surgery. One that has no complications, gets all recommended care. One who survives but develops permanent dialysis-dependent kidney failure, and one has a disabling stroke. Well, if you're just measuring mortality, those have all had the same quality. But in fact, we know that's not the case. The other problem, and again, this gets a little nerdy, but we have a problem with sample size, and it's not just in cardiac surgery, it's in all of healthcare. Anybody that comes to you with a quality measurement in healthcare, you ought to think about this. These are numbers of procedures, but it could just as easily be number of heart attacks or number of strokes at an institution. And this is mortality rate. And this is for an event that has an average mortality rate of about 2 out of 100. And that's a pretty common endpoint for many different kinds of complications or adverse events in medicine. These lines represent the uncertainty of our measurement. And the problem is that in healthcare, this is where we live. We live down at that left-hand side. Most hospitals are doing, at a maximum, a couple hundred of any one particular procedure. And when you're doing a couple hundred of any one procedure, you have this huge uncertainty. So if you really want to estimate quality, you have to figure out a way to get more endpoints or more sample size. It's pretty hard to get a higher sample size. So what we've done to address both the issue of comprehensiveness and sample size is to develop a family of composite measures that measure mortality, the occurrence of any of the major complications of surgery, whether you use the best conduit for the bypass graft, which is called the internal mammary artery, and whether you've used all the medications that are known to improve survival. When we roll that up into a composite score, a very sophisticated one, we develop an STS cabbage composite and then a star rating. That deals with both the issue of dimensionality or comprehensiveness of quality measurement and also sample size, because it gives you more effective endpoints. And over the years, using this quality measurement system with a composite measure, we have about 10 to 15% of programs that are either underperforming or performing at an extremely high level, and about 75%, even with these very sophisticated metrics, that are performing as expected. And an as expected program in STS is actually a very, very good program. In more recent years, we've seen exactly what we hoped would happen. If you look at the star ratings, the 1 star rating of 1 is the underperforming or performing lower than expected, and 3 is higher than expected. If you look over the years, you'll see that the percentage of those programs has actually been declining. What we'd actually like to do is get to a point where all programs were functioning at such a high level and were virtually indistinguishable. And then patients could actually go to programs that are close to them or have a particular preference, geography, or family, or whatever. We now have a family of these for all the procedures in cardiac, major procedures in cardiac surgery. This is about 80% of a typical cardiac surgical practice. And one important thing about our measures, again, getting to the transparency issue, we go to an organization called NQF, which I think the staff here will recognize. It's the National Quality Forum. It's the Good Housekeeping seal of approval for any quality measure. It is an extremely high bar, and we take every single one of our measures to them for endorsement. We actually have 34 measures endorsed by NQF, which is the highest number of any professional society, and we are actually a very small professional society. But we've made a commitment to try to have the best quality measurements around, and I think this speaks to that. And we're, of course, looking at many other kinds of measurement of performance as well, long-term outcomes, readmissions, appropriateness, resource use, and so forth. We don't just measure because we like measuring. The goal of this exercise is not to measure, the goal is to actually improve. These are the feedback reports that we provide to our participants on a quarterly basis, showing how they stack up compared to other programs in the STS, and also compared specifically to programs that are similar to them in terms of size and academic status. And we also give them their own results over a period of years so they can see how they're trending. We have data to show, this is a very nice paper that came out of the Brigham group a few years back, showing that over the past decade, we've had dramatic improvements in the adverse outcomes and also increases in the use of the internal mammary artery graft. And the authors point out, I think correctly, that the STS database has been instrumental in achieving that target by giving surgeons those regular feedback reports. We also use our data to establish evidence-based best practices. We have a quality initiatives task force within our database that helps to drive these initiatives, and a lot of it's based on work that's been done by Dr. Prager in Michigan and Dr. Rich in Virginia. We have webinars, and we're going to be instituting a program where we actually provide assistance to programs. Keith Nonheim talked about public reporting. If you go to our website, bring it up on your computer today, you'll see right there in black and white, we believe that the public has the right to know the quality of surgical outcomes and considers public reporting to be an ethical responsibility of our specialty. It's an ethical responsibility, it improves performance, it may impact the market. It's hard to prove that based on historical data, but we think going forward that's going to be the case. And importantly, it preempts less accurate metrics. We have a collaboration with Consumer Reports dating back to 2010, where they take our performance reports on programs that consent to have their data reported, and they'll actually publish that online. U.S. News and World Report, in their hospital ratings, provides transparency credit for programs that are reporting in the STS. We have our own very extensive PR campaign to get our programs to publicly report. And as Keith pointed out, 52% of adult cardiac programs and 58% of congenital programs are now voluntarily publicly reporting, either on Consumer Reports or on our own website. And again, you can go to sts.org, and you'll see page after page of public reporting materials. You can choose the procedures that you want to look at. You can choose whether to look by hospital or participant group. And then over on the right-hand side, there's a tremendous number of educational offerings so that people can go there and see things in plain English that will help them to understand these ratings. Star ratings for each program. You hover over the star rating and you'll actually get the numeric value, and it explains what that means. Percentage of patients who do not experience operative mortality in this case. And what we found over the years is that the programs that are publicly reporting actually have a statistically significantly better, lower mortality rate. So there's something about the process of public reporting that it's an important piece of information for a patient just to know whether a program is reporting or not. And those composite scores I showed you, every single reporting period, the programs in green that are publicly reporting have higher composite scores. So we think there's something very special about our programs that publicly report, and we hope that that number continues to grow. We have a number of government collaborations, and I just want to pick one of them, which is device surveillance. We, in conjunction with the American College of Cardiology, have something called the TVT registry. It's transcatheter valves for post-market surveillance. This is a publication that came out of the FDA, and I have a red arrow here pointing to one part of that wheel. That's both national and international device registries. And I think we have tremendous capability of providing real-time, real-life data to help monitor the safety of these devices. State programs, this is from my own state of Massachusetts, a program called NASDAQ, which uses STS data to generate performance reports for surgeons and programs in the state. This is from Rich Prager, incoming president of the STS. This is from his society, where they have formed a collaboration with the Blues to bring all the programs in the state in collaboration with one another to develop and disseminate best practices. This is from Dr. Rich, who will be the next speaker. This is from his initiative in Virginia, where they developed a statewide cardiac information system, linked clinical data to financial data, and have driven costs down substantially. Federal government programs, we are a qualified clinical data registry, which is very important. It means we've met certain criteria established by CMS. It also means that we can use some of these wonderful measures that we've developed in order to satisfy the requirements of what used to be the PQRS program, and hopefully we'll be able to do it going forward within the MACRA and MIPS programs. And finally, research. You say, well, not really all that interested in the research aspect of it, but how do we think it is that we make all these improvements in cardiothoracic surgery? Because we have these great data, we actually use those data to determine the best ways to do various things, to establish best practices. So this research we do, publishing huge numbers of papers, abstracts, presentations, and now federal grants, all these things are important in advancing care for our patients to get the best possible outcomes and value for our patients. So just to close, the STS database provides granular, standardized data that's quite different than anything else that's out there as a data source. We have robust risk adjustment. We have composite performance measures that I think are best in class. They're NQF endorsed, which is that good housekeeping seal of approval. We use these data to drive performance improvement. We use it for public reporting, and we use it for these government collaborations that I just mentioned. So with that, I'm going to turn it over to Jeff.
If anybody has questions for Dr. Shaheen?
No, I have some other stuff.
It should be, yeah, it should be queued up right next, or if you just hit next.
Yeah, so that was a little nerdy, just a little nerdy. Dave is a little nerdy, but he's really smart. Essentially what you just told us was that we've used the database for 25 years to improve quality because we're now comparing apples to apples and not apples to oranges. We're comparing, utilizing data that is not just real and accurate, but also clinically appropriate and standardized so that if I'm in a hospital in Maine and I talk to my buddy who's in Arizona, when I say they have congestive heart failure and he says they have congestive heart failure, we're talking the same language. We're doing absolutely the same terms. And you utilize those things, feeding back to the hospitals there. It's no different than an industrial line. You got a widget that has 20 steps to make, and the CEO's saying, geez, why is it taking 32 days to make to 20 steps for a widget? And they look at it and they see you can identify exactly where the problem is, fix that problem, and eventually, year after year, 25 years, we've knocked down the mortality rate for standard coronary bypass down from the 4 to 5% range. 4 out of 5 people were dying. 4 to 5 out of 100 were dying from that, down to about 1%. And the same has happened for valve surgery. So we've been making huge strides. And the point about the data is that it's not only that it's accurate, but it's available to us. All we have to do now is to take that, and what Jeff is going to talk to us about, is we're going to take that data and we want to link it to the cost and resource data from both, what he's done, he's done a great job, he'll show you, is link it both to the Medicare database and to the private hospital, the private payers database. If we can then identify who's got the best results, and it costs $1 million to get them versus who's got the same results and only costs $100,000 to get them, geez, we can start telling the $1 million guy or girl to start acting like the $100,000 guy or girl, and we can actually make it better. We can keep the same performance or even improve performance and cut the costs. And we do that by getting the information, cutting down or getting the best practices, cutting down on the complications, renal failure, atrial fibrillation, stroke. If we can cut down on all those complications, cut down the length of stay, they're out of the hospital, they're healthy, they don't cost as much. And that's the real power of this data. We can fundamentally change the practice of medicine and decrease the cost and improve the quality all by just using data. It's really damn simple. The only problem is we can't link this database right now to the cost data. That's what we really want to do, and that's what we need to help our congressional staffers, our congressmen, our senators, at CMS. We need to really collaborate with these people. If we're going to take this sort of to the next step, we've got to have the help of our friends in Washington, D.C. Jeff?
Thanks. And again, welcome to the staffers and all others. I think you know a lot about this. Many of you worked on this. Basically, SDR was in the field. NAPR brought in a quality payment program that has two arms, alternative payment models and MIPS. From a provider standpoint and from a professional society standpoint that has such a sophisticated database, you want to be able to use it. And I'll describe one way that we want to be able to use it in an alternative payment model and move our membership into MIPS, out of MIPS and into APMs. As you know, there are two goals in the Obama legislation. The harder one, the APM has softer goals in terms of timeliness of getting someplace, so 50% by the end of 2018. But if you stay in MIPS, there's expectation that you'll be active participants much earlier than that. This is sort of the APM framework. There are four basic categories, kind of what we're doing. What most people are doing right now is category 1. What we're doing is really strong category 2. Where we want to go is category 3, where we have an alternative payment model using the blended database with the financial database that you'll see. And then population-based payment is something now that we've been working on with ACP Land, the Healthcare Payment Learning and Action Network, because they developed a population-based model. We've commented on it, Courtney and I have worked on it a lot, and it's not part of regulation yet, it's not even there yet, but it's going to eventually evolve into that. So the key features of our proposal was to do sort of what we've been doing in Virginia, that was to take the STS financial or clinical database, our database, which you just saw and was so eloquently described, and blend it with CMS's financial database. So we had two trusted sources of data, and then begin to use it, as we did in Virginia, to identify high frequency or costly complications that we're seeing, and I'll show you an example of that. Develop best practice protocols aimed at reducing complications. We were tracking, looking at maintaining quality while reducing unnecessary resource utilization. And so we wanted to either maintain or improve quality along the way. And obviously, as you reduce complications, you're improving quality. So that's the basic foundational principle. This is some of our early work. These are our first two initiatives. HL2 is the complication after cardiac surgery. There were additive complications with that, and the transfusions as well. And I'll give you, I was just sitting there, I pulled up some summary slides for you. We were able to reduce those two complications and save substantial amounts of money. I just did this analysis. This are the additive costs of complication. Every time you have a complication, a baseline cappage is in the blue, and every complication has costs associated with it. So we're able to use the database to identify those costs, and then look at the ones that have very high impact, like renal failure and prolonged ventilation at the end. And in the last 5 years, 4 years only, we looked at all the cardiac surgical procedures. There was $1.8 billion spent in Virginia, but the actual cost of complications was $506 million just for cardiac surgical procedures in general, and $124 million for CABG alone. So there's a lot that can be done with the database, and our plan was to develop such a database and use it nationally for the entire country, obviously. So this was just an update. Just in atrial fib and transfusions, we're now up to $115 million in savings by reducing those two complications over time, maintaining best practice protocols, sharing them in the state. And now we're working on prolonged ventilation and postoperative renal failure. Those were the two most costly that I showed. We're having progressive reductions in those in the state using best practice protocols and sharing and doing site visits to the high-performing centers. So our plan now is also to work with the ACS and Brandeis University, because part of all of this, of course, as we move forward in MIPS and alternative payment models, is that we need some way to attribute the cost, because we're moving in a direction. Not every APM is going to be a bundle payment, but when you do have a bundle payment, you have to figure out what proportionality and attribution that you have. It's very complicated. I worked on it when I was at CMS, and we're working on system logic for the groupers that are being used to develop this. It's a very important key component of anything that we're doing here, either MIPS or APMs. And we want to add a strong quality component, and obviously we want it to be our database for us at least. There's a quality payment plan or quality plan at CMS to develop some measures where professional societies don't have them, but we feel that we're way beyond that at this point in time. And then developing episode-based and other types of bundle payments. Really, when we did some of the prototypes in Virginia, we wrote a bundle payment plan in 2003, and had trouble implementing because of Stark regulations. But it created so much care coordination, because you're actually clinically and financially responsible for that episode of care, and you're actually talking to everybody that's involved instead of being siloed. So, but again, to do that, that's going to be very difficult without good attribution models. This is the ACP Land APM Framework I talked about that we're trying to participate in, writing the white paper. We're trying to get into, here's so small for me, but the circle, the episode payments with shared savings. So part of the initiative for the APM for the STS is that, look, we're willing to work to reduce costs of the complications and to create healthcare savings, but we want to share those savings. And that's how we want to move our payment schedule ahead, not by just doing the work and seeing everybody else gain from it. Obviously, CMS and the whole healthcare system is going to gain from it, including payments, but we want to create a strong component of shared savings in that. So what's next? We have a joint submission, American College of Surgery, to the physician-focused payment model technical advisory committee, and another committee that was formed to look at these APM proposals. It will contain all the elements that I just described. We're doing direct outreach to CMS and CNMI. Let me get back to this. So educational outreach. From the HCP land, the BCSQI was just awarded a $3 million grant to do educational outreach and teach clinicians about APMs. And it's going to start in Virginia, and then the Prager's authority move into Michigan, and then hopefully, if it's an effective plan and it works, then hopefully the STS leadership would, consider us and let us do outreach across the whole country. And it's basically to get people to understand and get ready for an APM. So if we develop an APM, we need an educational component to teach our members how to use it, and so that's what that is all about. So I think we have a lot of strong things. We're asking CMS to help us get the data from claims data. We're working on pathways for it to happen. It's not that easy. Virginia is very special because we have Virginia Health and Hospital Association, which has a mandatory collection for all payer data, and then it's shared with us a little bit harder on the CMS side, but we're working through those pathways. So what's stopping us? This probably should your slide, Courtney.
Do you want me to take it?
Yeah, go ahead. You do it so eloquently.
Hi everyone, I'm Courtney. I'm Director of Government Relations for STS. And so, I think the point here is that what you all did with MACRA and passing MACRA gave us a lot of opportunities to leverage the resources that STS has built over time and really turn this into something that could be worthwhile in a payment space. I think that, everybody's talking about paying for quality, and it's hard to define what quality is. Well, guess what? We know what quality is. We just need help with the payment part. So MACRA gave us these opportunities. They gave us PTAC. But PTAC doesn't mean that we're going to get our APM approved. It doesn't mean that our APM is going to be implemented. So we're doing other things. We're reaching out directly to CMS. We're reaching out directly to CMMI. We're trying to get these things piloted to demonstrate that pay for quality really does work. So, that's going to be an uphill climb for us over the next couple of years. But we're also in the middle of, I think that you're all aware, we're in the middle of just a huge amount of regulatory stuff right now. The MACRA rule came out on Friday. It is 2,398 pages long. I'd be happy to brief all of you on it at the end of this meeting. I still have a couple more pages to go, but we might get it done before we're done. We're still waiting on the fee schedule, and we still have some of the annual CMS rules. And there are a lot of things in there too. There are some policies that we've been working with many of your offices on data collection for global surgical payments. And I can get into that. It's a little bit off topic, but just a lot of programs piling up in the space where I think that Congress intended for us to be working with CMS to innovate. So instead of being able to focus on those priorities, instead of being able to focus on bringing our ideas to CMS and working together on how we can help to make the health system better, we're dealing with a mandatory bundled payment from CMS in the form of, and you heard Dr. Shaheen and Dr. Rich talk about CABG. I'm not sure if everybody knows what CABG is. It's coronary artery bypass graft surgery. It's what you think of when you hear somebody says, oh, I had a triple bypass. That's what we're talking about here. I think it's probably it's a good point to example for what these surgeons do, because I think it resonates with a lot of people. I think that a lot of people have that experience. So that's why, part of the reason why we're using that as an example. CMS came out with a mandatory bundle payment for CABG, very similar to the joint replacement bundle that came out last year. Unlike the macro statute, which calls on CMS to work with us on designing these types of things, we didn't have a seat at that table. We got the bundle payment. We're happy to work with CMS to try to make it better, and in fact, we've given them some very constructive comments, and we're hopeful to see those things implemented, but we would have preferred to have had some of these ideas on the table to begin with. So I think that's what this slide is all about, and maybe way too many words, but I'm happy to talk about any of those things, the policy-related things, but I'm going to turn it back over to the expert.
Hey, Courtney, before you leave, could you just explain how the mandatory bundle payment for CABG, where that came from, who put it together, who had input? We did, so those.
I think that this is part of clearly Congress sent a message that alternative payment models were a priority, and I think that CMS has sent a message over the past couple of years that alternative payment models are a priority. We've been a very clear message. That there was an announcement by the Secretary that they want a certain percentage of physicians in bundle payment or in alternative payment by the end of this year, and they claim to have reached that goal, and they have a larger target for 2018. So this is all folded into that initiative. This is part of CMS and CMMI through the Affordable Care Act generating alternative payment models, which is great. I think that we all agreed when we were working to pass SGR that we needed to get out of the fee-for-service medicine space. We just want to be able to contribute some ideas to that space.
So the direct answer came from CMMI up to CMS leadership. And part of the bundle design was also at this HCP land. They not only had the population-based disease management model going on, but they had the bundle. We went to the meeting, and I went to that meeting in particular, and they had different ideas with the MITRE Corporation, where you can get another attribution model, while CMS was running down a parallel trend. CMMI working with American College of Surgery and Brandeis on yet another act. So it's moving fast. It's coming along real fast. And most of those bundles came out of CMS, the bundle care, better care performance improvement.
Yeah, and on a very superficial level, it seems incredible that something would be developed without input from the people who actually perform the procedures. And it gets to underscore the notion that, we are willing to work, want to work, and try to help and get something further down the road. So I think that's one of the frustrations.
And I met with the leadership at the ACP land and made that point very clear, and we actually got a seat at the table. But there were people that I had worked with, and I explained to them how dysfunctional this is for us not to be involved, and that we do have great ideas. So we do have some voices there now.
To be clear, the HCP land is Healthcare Payment Learning and Action Network. This is a CMS-funded initiative, subcontract to the MITRE Corporation, and it's largely CMS collaborating with other health insurers to try to benefit from collaborations and ideas that are happening in the private marketplace that could also be translated into the Medicare space. So, and Dr. Rich mentioned that there was a proposal that came out of the HCP land. That was more of a population-based bundle, so if you remember that there were two different charts, one showing what CMS has outlined for alternative payment models, and then one that drilled down a little bit deeper, the HCP land, which is basically itemizing the different types of payment models that would fall under those broad categories. And we said that we were in a 3 and circled one of the ones in the 3. So the HCP land proposal is a population-based proposal that's firmly in 4, but as Dr. Rich suggested, that's probably some years down the road even for us, although we are uniquely situated in that this particular area, this particular specialty in cardiothoracic surgery and cardiology is also the place where you have the largest source of quality data. The American College of Cardiology also has a registry that has been around since the late 80s, and so it's our hope that at some point we can come together and collaborate on those types of initiatives. I think we're ready for questions. I think that's the last.
That's this last slide.
You have a question. I know you do. Ask your question. You always do.
Didn't have in mind. Think about it a little more.
So the whole idea of this is we are trying to insert ourselves into the Washington biosphere. We sort of have been, for years, a specialty, a lot of medicine, and didn't really participate. And in the last 20 years, it's become clear that if we don't have a seat at the table, we will be on the menu. So we need to collaborate with congressional offices. And we are going to need your help to help nudge CMS to let us in the door, to get our foot in the door. The idea that they would have put together a bundle, a payment model on something that we do, it's kind of like saying you're going to put together a car payment model for GM without asking them what the specs on the auto are. It just doesn't make any sense. We will.
The point, Keith, too, you might want to make is this represents $150 million in one state. If the STS does this in 50 states, you can do the math. That's with only 2 complications, and we're working on 3 others already and showing reductions there. So it has enormous potential for savings, saving the healthcare system. And that's why we sort of want to get your support.
Yeah, and the models that they're putting together, the attribution's going to be critical. What we want to do is make certain that the models they put together accurately represent the real costs and benefits that occur from coronary bypass, from aortic valve, from combinations of those. And I will say that though cardiothoracic surgery is, in terms of majority of cardiothoracic surgery, is actually heart surgery. There are other subspecialties. We do congenital heart surgery. We have, doing the little tiny, poor little kids with the little walnut hearts that look like frog hearts because they're all misshapen and stuff. Those guys do amazing work, and they are in the quality reporting realm as well. They do a great job. And we also are responsible for a good portion of the lung cancer, esophageal cancer, all the other chest surgery that goes on that does not deal with the heart. There is a database for that as well. So we are essentially trying to collaborate both with your offices, with CMS, with CMMI. We think we have a lot to bring to the table, a lot to offer. We can improve quality, we can save money, and we're just asking for your help to make that a reality.
So practical ways that we can actually ask for your help. I think that we are in, just as you all are, in a waiting period, waiting for these rules to play out. But I think we're hopeful that you all will take this back to your bosses, continue to monitor the regulatory landscape, and I don't think that we're going to be the only specialties banging down the doors to try to get these opportunities. So hopefully, as you hear from other constituents and other constituent groups, we can find a way to collaborate to bring some of these ideas out.
You want to talk about the global, or that's just too much in one session?
Is anybody here familiar with the issue related to global surgical payments? It's kind of arcane, but it's a big deal for the folks in this room.
Essentially, the surgical global was something that passed way back in RVRDS, way back in 1989, and even actually before that. And what it says is that the whole idea that the frustrating thing about it is that CMS wants to say, all right, the year 2020, 80% of all payment will be in a bundled payment. Well, yeah, we've been doing bundled payment for like 25 years already. And so they now want the one bundled payment that's actually worked, that is the 90-day surgical bundle. So they pay us, I see the patient in the morning of surgery, I do my operation, I take them to the ICU, I deal with them there. They're in the hospital for 5 days, I'm taking care of them all those times, and then I see them the first post-op week, second post-op week, and damn, if they have a complication anytime for that next 90 days, I'm seeing them. And that's all paid for. One payment, just one single payment. And now what they want to do is they want to say, geez, you know what, it's the one bundle that actually works, and now they want to break it up and make us give a separate bill in the morning, I see the patient, and this is in 10-minute increments. They want it like a lawyer, right? I'm supposed to have like an umpire, like, click, 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 okay, that was 10 minutes, click, 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 okay, now I'm seeing you, click, 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 it doesn't make any sense. And in 10-minute increments, I have to now bill for all the care I give the morning of surgery, the day I operate, the day I see that same day I operate, I see him in the ICU afterward, the next day, the 5 days they're in the hospital, and the 90 days thereafter, I'm supposed to submit a separate bill for every 10 minutes of care throughout that 90 days. And our suggestion is that just for cardiothoracic surgery alone, it would be like 100 million more bills. And it's not only onerous, but it's gonna be costly for them to analyze them, to pay for them, for us to submit them. We're gonna have to like hire lots of new billers and coders. It's just so crazy. It's gonna massively increase our compliance costs and our administrative costs, and it's not gonna help them one little bit. So it is a major, they wanted to do it last year. Thank God you guys, Congress stepped in and said, come on, that's just not fair. That's a little crazy. And what they said is that, you know what? You want the information? That's okay. We can understand. You can get the information. And so the congressional offices put in the legislation. They said, why don't you go ahead and get a sample of patients, a sample of doctors, and find out how many visits they have, and have just a sample of doctors go ahead and submit those bills. So they said, sure, a sample of doctors. And they said, I'll tell you what a sample of doctors is. 100% of doctors, 100% of the operations, 100% of the time. It made no sense. They are going to make this massive compliance web, this swamp we have to go into because they want a sample data. They don't need 100% of 100% of the operations 100% of the time. What we ask them to do is do what Congress asked you to do, get a sample. And 100% really isn't a sample. It is a sample, it's a damn big sample, but it's an unnecessarily big sample. And what we really are gonna ask you to do is to tone it down, and hopefully in the final rule, when we don't know this yet, as far as I know.
Right.
In the final rule, we're hoping they'll change it, but if not, we're gonna come on our hands and knees begging you guys for help, because it's an unnecessarily onerous and costly mandate that really won't give you any information.
And to be, we have, so, I mean, as Dr. Nonheim described, this is, CMS really needs to do some data collection in this space. They felt like they didn't understand what was in this 90-day global payment. They wanted to understand all of the services. So their idea to do it was to just break it down, just to blow it up and have all of the individual services billed for. We came to you and said, please don't let them do that. It's going to have a very negative effect on patient care, because in a time when we're trying to promote care coordination under this larger umbrella of global payment, you're gonna fragment care again. And so in MACRA, there's a provision that told them, okay, fine, if you wanna do the data collection, do the data collection, but do it from a representative sample. CMS has come out in the proposed fee schedule rule and said, we don't quite know how to do the data collection, so we're gonna try to do it from everybody in these 10-minute increments, which is a non-starter. We've come forward with other ideas. We and the rest of medicine have come forward with other ideas on how they could possibly do this as a sample. And so we're hopeful that they're gonna take us up on those suggestions. If they don't, in the final rule, we're expecting it in a couple of days, the beginning of November. There's gonna be an issue of, legislative intent, really, because the statutory language does call for a sample size, but I think on a broader level, just what this is doing is taking a step backwards in care coordination, when really we were attempting to, in all of these efforts and the rest of this space is trying to coordinate care and drive quality.
It's not just an impact on us, it's impact on patients. Medicare beneficiaries, instead of getting one bill, now they get 110 bills for a procedure. And it's a huge impact on the payment system. Because the Medicare administrative contractors, there's 13 of them, right? We designed them when I was at CMS. They're the ones who do all the billing. They process the claims. And the claims are going to be enormous. You're going to have to appropriate money to build out 15 more Medicare administrative.
I think there were going to be over 500 million claims in the market. It was crazy.
I don't think that the patient necessarily sees all of those, but the CMS definitely has to figure out how to handle that.
Depends on the copay. The copays.
Right, but the G codes that they're requiring are not actually billable.
What if we just go back and say, hey, this is a great thing, we're going to do this as soon as you do the same thing for DRG, the hospital, and take every single point that they're in care, every Band-Aid, every IV, every telemetry, monitoring event, and bill for those individually. How about that? It's that crazy.
It makes that much sense.
It's that crazy.
Are there any other questions?
Yes.
So in the advanced payment model, it's a risk-sharing model. How do you see savings for atrial fibrillation or renal failure or prolonged ventilation? How do you see that risk-sharing and the savings intertwined? I mean, is that in the model in some way?
Well, I think that all the components of your total shared savings program is going to, atrial fib or prolonged ventilation is going to move up to savings, and then there'll have to be shared agreement models with shared savings models.
That hasn't been worked out yet, anything like that?
Yeah, it has been in the ACE demo. I put that together when I was at CMS. The ACE demo had a shared savings model. We had, and I worked with the Department of Justice to create safe harbor rules and regulations so that you could share in savings, but you couldn't get more than 25% of your Medicare allowable, which is a pretty big raise. When's the last time you got a 25% raise? So there are methodologies already in place. You could go outside of that. You could create your own shared savings models, but they have to be transparent and they have to be registered. And it could work either way. And it could work either in hospital employment or in the private sector. You just have to be transparent. And it's a little bit harder in independent practices to work with hospitals to start sharing in savings, because then you need basically either a third-party administrator who collects all the money and figures this all out. And in Virginia, it was going to cost us about $750 million just to get a third-party administrator to fairly adjudicate that stuff. Under hospital employment, you have a service line cost center. It'll be easier to work it out there, and then the contracts that you have with your hospital, under your employment, you'll just have to create a deal for shared savings. Showing that you're willing to help. Most of these savings fall to the hospitals, right?
But
And hopefully back to the government. There's methodology.
And we're not asking individual hospitals and individual providers to figure that out. CMS will figure that out, and as Dr. Rich said, there are models that are already out there that they will base this on, including the cabbage bundle. The architecture of the bundle payment is not necessarily something that we object to. We just think that we can do a better job of showing them more quality.
And CMS has already figured it out. The model I was describing to you is prospective payment methodology, where you actually have to have a third-party administrator and all that. The proposal and the bundles that are coming out are retrospective reconciliation. So the providers will still get paid like they do under the fee-for-service system. So they're using the fee-for-service architecture. You're still going to get your stream of income, and then there'll be retrospective reconciliation, and there'll be one accountable entity that they have to reconcile with. And so it could be a penalty or it could be a profit, and then it has to be shared among all the providers, or penalized among all the providers.
I'd just make a comment as well for the congressional staffers who are here. I don't think it should be lost on you the impact of the demoralization of the workforce of all medicine. So you've got electronic medical records coming into play, you've got very complicated payment models coming out, you have this regulation where you're going to now measure by 10-minute increments that Courtney referred to. The impact of that on the practitioner, be it surgeon, primary care doctor, I can tell you is enormous, and I don't think that is ever factored into it as all this stuff sort of comes together at one time, but everybody looks at this and they see January 1, we've got to start collecting all this data for global payments, electronic medical records by a certain date. All these things have a tremendous impact on morale in medicine.
Any other questions we can answer for you guys? Well, thank you for your participation. If you have any questions, once again, Courtney has a phenomenal staff here in Washington DC. You have their contact information. Either Jeff or Dave are certainly open to answer any questions if you have any other questions on our suggested payment model or on the database. And I thank you for your attention and your time. Thank you.
And feel free to take some